Now I'll invite Dr. Prabhakar for delivering the talk of Dr. Nilesh Mohan. Unfortunately, he couldn't make it. Dr. Prabhakar is from All India Institute of Medical Sciences, New Delhi. He has done his MD, fellowship from LVPI, and now working at AIMS Patna. Wonderful corneal surgeon. He'll be talking on insight into anterior segment OCT. This is out of turn presentation since he's also guiding two students in TOT. So he has to be there. Thank you.
Dr. Nilesh. So very good afternoon, and thank you so much, sir, for such a wonderful introduction. So I will be presenting on behalf of Dr. Nilesh Mohan, sir. So I will be talking on anterior segment OCT, and so basically we know that we have a newer, modality in our armamentarium as an anterior segment, that is the anterior segment OCT, which is of a great help, and we know that what is the main advantage of this ASOCT is that it is a non-contact procedure. So if we talk about, say, even ASOCT or an UBM can also give you much more information as the ASOCT, but the basic difference between the two is that the procedure is a non-contact procedure and it does not require a skilled operator to operate. And of course, it is giving you a higher axial resolution, and the acquisition time is also less. So it is definitely giving you more information because it's more axial resolution is there with ASOCT compared to UBM. So it's a greater tool. I'm not talking about the mechanism per se, but I will let you know. Sorry, I'm sorry. So, so what are its applications? We do anterior segment OCT in cases of corneal and ocular surface diseases, anterior segment surgery, and as well as in glaucoma. So as far as ocular surface diseases are concerned, we can map the ocular surface. We can see not just the ocular surface, but also about the corneal thickness in different diseases. We can identify the level of deposition of different, say, macular dystrophies, how deep your deposits are there, or whether it is involving the deeper layer or endothelial layer or not. It is helpful in finding Descemet's membrane detachment in patients with cataract surgery. If there is a persistent corneal edema, you are not able to see on slit lamp the extent of Descemet's membrane detachment. Anterior segment OCT is a great help to identify that and subsequent management. As far as opacities are concerned, we can actually measure what is the depth of that particular opacity, and we can manage accordingly. And we can either go ahead with simple anterior lamellar keratoplasty or whatever is needed depending upon the depth of involvement. Apart from this, as I said, if you're doing DALC, again, post-operatively, you can assess whether what is the extent of the double anterior chamber, and you can go ahead and rebubble and try to settle the double anterior chamber. Similarly, for DSEC that we do for bullous keratopathy patients, we see that how well the graft is attached to the recipient. So we can go ahead and see on ASOCT very well, though we can see it even on slit lamp. But when the cornea is very much edematous on first post-operative day, which is very crucial, because if it is detached in the first post-operative day, you can go ahead and quickly rebubble and help it reattach. As far as implantation of intrastromal ring segments is concerned, you can see very well over there that we can judge the depth at which you have implanted it. So usually we say that it is 60 to 70% depth that is preferred, and we can see it here. So it gives you a lot of information, just not helping in making a diagnosis, but also later on to follow your patients. Similarly, in various corneal ectasia disorders like pellucid marginal degeneration, or even for that matter keratoconus, you can see the extent of corneal thinning or any sort of scar, or the level of scar if it is a healed hydrops. And definitely in bacterial keratitis also, you can go ahead and do anterior segment OCT, and you can find the level at which, till which the infiltrates are reaching. Apart from that, you can also judge the areas of thinning in cases of healed keratitis. Yes, so again, these days we have shifted significantly. Previously, we used to go for, in cases of OSS, and we used to go and we used to do biopsy. And but these days, with the help of anterior segment OCT, what we are doing, we are nowadays we have, I mean, limited ourselves, and we don't go for surgical management. Rather, what we do, we just go ahead and do an anterior segment OCT. We see the abrupt transition in the epithelial cell caliber, and this is how we make a diagnosis. So even for that matter, the impression cytology has lost its role, and largely we are making our diagnosis based on the anterior segment OCT images, and accordingly we treat, and we even follow up based on the anterior segment OCT pictures. Similarly, you can identify the level to which the foreign body has entered into the cornea, and accordingly you can decide your plan whether you can take it or do it in the just in the OPD setting, or you want the patient to take to the OR. Intraoperative OCT, yes, that is of great help. That tells you as to how deep you are working into the cornea. So definitely it is a great help in DALC, DSEC. You get to know on table, okay, my graft is still not attached, so I need to rebubble. And yes, anterior segment surgeries like LASIK flap, we evaluate. So again, here, even in the, for that matter, in LASIK, post surgery, we can follow the patient. If there is any sort of, say, infiltrate in between the flap and we're not able to make out it properly, we can go ahead and do anterior segment OCT to find the extent. And we can also, we see, apart from this, we can also see as to how, say, if you have done a case of LASIK and you want to assess how smooth is the interface. So again, this helps you to choose which one is better for you or which works better in your hand. So as far as glaucoma is concerned, yes, you can do this, use this modality in even in malignant glaucoma. You see that the central anterior chamber depth is completely obliterated, and subsequently, when after treatment, after hyalodotomy, the anterior chamber is deepened again. Apart from this, there are various features that you see, the angle structures you see the bleb morphology, and yes, and you can also do anterior segment OCT in patients where you have implanted shunt. So you can see the relation between the tube and the corneal endothelial cells, or the corneal endothelium per se. Apart from this, you can also see the patency of the shunt tubes. And these are the different quantitative parameters that are helpful in identifying as to how is your angle structures. And so obviously, gonioscopy is the gold standard, and we cannot say that anterior segment OCT is better than gonioscopy. Your clinical findings are always, or examination always is takes the upper hand. However, still anterior segment OCT is a good tool to complement gonioscopy. So to conclude, a wide range of corneal and conjunctival pathologies, and it has a multiple use in corneal pathologies, conjunctival pathologies, and glaucoma. It is quick and rapid. It is a non-invasive procedure, and even it does not require a very skilled person to do it. And it can be utilized even in an immediate post-operative period. So with this, I would like to conclude. Thank you.
Thank you, Dr. Prabhakar, for wonderful talk given to you at very short notice. Thank you
Thank you
for
so much.
your ready